thank you all for being here at the first panel of the Mitchell Center's Undergraduate Conference. Every year, the Mitchell Center has approximately 10 undergraduate fellows, and at the end of the spring semester, they present their work at an all-day conference. This is obviously a very special conference because it's on Zoom, but we're very happy to be pushing forward and celebrating the excellent work that the fellows have done over the last year. I want to thank Matt Roth, who's been instrumental to every aspect of the undergraduate program, and also Matt Schaefer and Gideon Cohen-Postar, who have taught with me the undergraduate seminar at the Mitchell Center this year. We're very lucky to have with us as our first panel on health our two presenters, who are Angela Kumirai from the Health and Societies major in the History and Sociology of Science department, who will be presenting a paper on healthcare financing in Botswana and Ghana, and also Morgan Taylor, who's also from the Health and Societies major in History and Sociology of Science, who will be presenting her thesis, An Untold Story, Understanding the Black Maternal Mortality Crisis Through Preeclampsia from 1940 to 2020. And we're also fortunate to have as our discussant today, Raymond McCay, who's an assistant professor in Penn's History and Sociology of Science department. In addition to many other works, she's the author of the 2018 book, Medicine in the Meantime, The Work of Care in Mozambique, which was published by Duke University Press. The book traces the lives of two medical projects in Mozambique. It explores the question of how medical care is constituted and shaped through diverse actors, aims, and temporalities in attending to the variety of interhuman relations through which care is made possible. Ramah's book aims to understand both the effects and limits of transnational medicine today. More generally, Ramah works at the intersection of various disciplines and methodologies, including ethnography and anthropology, the history of science and medicine, and science and technology studies. So thank you so much for being with us, and to the student presenters, we'll turn things over to you. Who is going to speak first? Angela, is that you?
I can go first.
Okay, thank you.
That's okay with you, Mo.
Oh, I'm so sorry to interrupt, but anyone who wants to ask a question, just write your name in the chat. And once there's time for Q&A, I can moderate that question and answer. So Angela, the floor is yours. Thank you.
Hey, thank you so much for being here. And I am happy to present to you what my capstone project was about. So it was titled Healthcare Financing in the Developing World, and it was a case study of Botswana and Ghana. So one of the United Nations Millennium Development Goals for 2030 is to achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. In developing countries, universal healthcare is a milestone that ministries of health strive to achieve in order to bring access to health services to all. Countries in Africa have been working towards this goal, and two countries stand out in being very far ahead in achieving universal healthcare coverage. These are Ghana and Botswana. Access to healthcare is a prominent goal. However, the quality of healthcare provided is also very important, as it provides better outcomes for the patients and makes the use of government monies more efficiently utilized when allocated to healthcare. The study investigated the quality of health outcomes in countries with two different health access models. For the countries that I chose were Ghana and Botswana, because they have achieved universal health access using two different models. Ghana's health system is supported by mandatory contributory premiums under a national health insurance scheme. Botswana's health system is supported by government revenues from minerals mined in the country. Now, the variability in population sizes of the countries was taken into consideration using per capita values. To control for environmental factors that influence health, the country's top 10 causes of death were examined, and there was a general agreement in the diseases that afflict these 3 countries. The countries that are highlighted in green on the slide are both shared by the countries, by Botswana and Ghana as the top causes of death. Then I could not really control for differences in gross domestic product per capita for the countries. And you can see that Botswana is much wealthier than Ghana. Now, the conclusions that I drew from this study was that government spending was higher in Botswana. Out-of-pocket expenditures, however, were higher in Ghana. But then there was more rapid improvement in health outcomes in Botswana as compared to Ghana, which had a steady improvement of health outcomes. Now, the claim that I make from this study is that contributory health insurance schemes are not the most efficient or equitable ways to finance healthcare in low-middle income countries. And the evidence that supports this claim is that Ghana has achieved universal health coverage through mandatory contributory insurance schemes, but its health outcomes are steady, showing little improvement. And Botswana has achieved universal health coverage through revenue, government revenue from minerals. And Botswana's health outcomes are rapidly improving and outperforming in areas such as maternal mortality. So rather recognizing healthcare, this claim supports that healthcare should be recognized as an essential human right, and using country resources to fund it is more efficient in providing quality and outcomes for health in developing countries. So through this study, we saw that the model of financing healthcare is translatable to quality outcomes of health in countries. Each year, Botswana receives more aid per capita from external sources such as the World Health Organization and UNICEF. The observation that Botswana received more aid from external authorities on a per capita basis ties to the next bullet's discussion of democracy. Foreign entities are more inclined to provide countries that have responsible governing aid, because responsible governing is equal to accountability. According to the Economic Intelligence Unit produced by The Economist, Botswana is second in Africa in terms of quality of democracy, and Ghana is 5th. So Botswana is considered more democratic, hence receives more funding. For further research, I would like to see an investigation as to why Ghana's contributory health system is not as efficient in improving health outcomes. The results were steady and not improving as dramatically as Botswana's. I would also like to see an investigation into government allocation of mineral resources in Ghana, because Botswana has dedicated part of their diamond production revenue to healthcare. Ghana is also very rich in gold, as it was once called the Gold Coast. It is very rich in cocoa, which is imported by many countries to make chocolate all over the world. And it is rich in uranium, which is yet to be exploited. So what are the revenues from those natural resources being used for? And is it worth redirecting those funds to healthcare, which would be a case for healthcare funding? So thank you. I have included the graphs that showed the trends in the appendix section, and I'll open it up to any questions.
Thank you so much, Angela. I think what we'll do though is have Morgan present her research and then hear from Raymond McKay and then open it up for Q&A. But if you do, anyone in the audience would like to put themselves down on the queue for questions, just type your name in the chat and then we'll come to you. So we look forward to the Q&A part. Thanks again, Angela.
Hi, everyone. Thank you so much for coming this morning to come listen to us present, and to the Andrea Mitchell Center for giving us this opportunity. Today, I'm going to be speaking about my senior honors thesis for the Health and Societies Department on the Black female maternal mortality crisis in the U.S. titled An Untold Story, Understanding the Black Female Maternal Mortality Crisis Through Preeclampsia in 1940 to 2020. So through my thesis and my presentation today, I hope to bring more light to the history of the Black female maternal mortality crisis. So to kind of give you guys a plan for today, I'm going to start by giving an overview of my project and then going over the main problems and the significance. And then we'll broadly take you guys through the history and the story that I tell in my thesis, and then go into one of the testimonies that I use in my thesis, Deidre Johnson's story, and talk about the significance there and how that plays into larger trends in the Black female maternal mortality crisis, and then wrap up by talking about the conclusion and where we go from here. So my project aims to look at the history of the Black female maternal mortality crisis in the US, and in doing so is really looking at the individualized blame narrative that places the majority of blame and responsibility on Black mothers for the Black female maternal mortality crisis, and in doing so puts more pressure on them and making it an individualized problem instead of a systemic issue. And so to do this, I look broadly at the Black female maternal mortality crisis, and then specifically looking at preeclampsia, one of the most severe pregnancy complications that also disproportionately affects Black women, for no scientific reason, to really understand the effects the individualized blame narrative is having on Black mothers. And then lastly, I'm looking at how the rise of advocacy, specifically over the last 10 years, has affected the perception of the crisis at large. And so I was inspired to pursue this thesis just because of my own personal ties to the issue, since I was born via emergency C-section and know many other Black mothers who've also gone through similar complicated birthing experiences, and wrote my first paper on the topic my sophomore year at Penn, comparing the 1950s to present day. And doing so, saw very little change in the data around how many mothers were dying, but saw a lot of change in perception and levels of advocacy. So in doing so, I saw a huge gap in the scholarship, specifically looking at the longer term history of the crisis in the US. And this is what inspired me to write my thesis, which feels ever more important now as the urgency around the issue is only increasing and more attention is being paid to it. So for the remainder of this presentation, I'm really going to focus on telling you guys the story that I've cultivated to defend my overarching thesis, which essentially states that this individualized blame narrative has had a detrimental effect to Black maternal health and the perception of the crisis at large, and that over approximately the last 10 years, the rise of advocacy, specifically stemming from Black mothers, has led to a general shift in the perception around the Black female maternal mortality crisis. So it's important to understand that throughout this paper, I'm really looking at what I've been deeming as the individualized blame narrative. And I've defined that as a narrative that puts the majority of blame and responsibility on Black mothers for the Black female maternal mortality crisis, thereby saying that whatever complications they end up experiencing, or even death in certain instances, they're holding up more of the blame than larger systems in the US, like the public health system and the medical system. And then even though my paper technically starts in 1940, it's really important to understand the longer term history of racialized medicine in the US. So if you look back to the 1800s during slavery, you really start to see a solidification of racialized medicine and certain biases and attitudes being propagated. And an important example of this is Dr. J. Marion Sims, who's known for practicing inhumane experiments on Black mothers and seeing Black women as lesser than white women. And then overall, Black slaves were really used for medical experimentation. This really solidified certain beliefs, like Black slaves having higher blood pressure, not being able to feel pain. And these beliefs have continued to affect the larger African American population, but specifically in this instance, Black mothers up through today. So starting in 1940, we see one of the first public health records come out about Black maternal mortality. And this public health record comes from the Children's Bureau, and it's titled The Negro Situation in America, Studying Black Mothers and Infant Mortality. And so it was written by a scholar named Elizabeth Tandy, where she's looking at data between 1936 and 1938. It's important to realize that Black mothers obviously didn't just start dying in the 1930s from pregnancy-related complications, But this report serves as a large milestone in the fact that it's one of the first times we see Black maternal mortality noted in a national public health record. But as much as it serves as a milestone, it also plays an important role in solidifying this individualized blame narrative, because in that report, Black mothers are deemed to be ignorant, incompetent, and racially predisposed to certain complications, thereby again putting the responsibility on them for complications that they experience, and even in some cases death. And then additionally, during this time, maternal mortality at large is being defined as a white female problem, which is really important to recognize because it sets a precedence going forward. So when maternal mortality is being addressed and we're looking at ways to address it and potentially cure it, it's looking at it from a white female perspective, and often sidelines Black females and increases that blame narrative being placed on them. So then moving forward to the 1960s, we see a large rise from the medical community, specifically physicians and public health officials, saying that maternal mortality is curable and that the way to cure it is through prenatal care. And this general prescription of saying that prenatal care is curative has a really detrimental effect on maternal mortality at large, because it's saying that essentially that if a mother is unable to get adequate prenatal care and succumbs to certain complications, or even in some cases death, that it's no longer the physician's responsibility because they have no control over the mother's behavior. And we really see this when you look at preeclampsia, where one of the main treatments for it is getting prenatal care. And this really disproportionately affects African-American women during the 1960s specifically, because of how many racial barriers are in place around the medical system that really prevent them from getting adequate prenatal care, and automatically then put them in this category of blame for their own complications and possibly death. And so in the 1980s, we continue to see this general prescription of prenatal care being curative, but at the same time, there's this rising narrative of villainizing Black mothers and really trying to say that they're unqualified for motherhood, going another step farther from just saying that they don't deserve proper maternal care while pregnant, but that they're not even qualified for motherhood. And one specific example of this is the 1986 CBS special report titled "The Vanishing Family Crisis in Black America," where Bill Moyer essentially states that Black mothers are responsible for all moral depravity within the Black community. And reports like this and this narrative that continues to grow during the 1980s does more than just define Black women as welfare queens. It's saying that they're unfit for motherhood and therefore undeserving of the respect that comes with being a mother, and therefore spreads through their maternal care while pregnant. And this unfit motherhood narrative really stems again from these ideas that Black mothers are ignorant and they're incompetent, they're unable to maintain significant relationships with the father of their children, and that they're more sexually promiscuous. So again, just villainizing them, putting them in this other category of not deserving proper maternal care. So moving forward to the 2000s, we start to see a rise in maternal mortality and awareness around this. And when I'm saying maternal mortality, again, it's in white female maternal mortality. So as more attention is being paid to that larger maternal mortality crisis, Black females continue to be sidelined and responsibility continues to be placed on them. And additionally, during this time, we see a rise in conversation about how implicit biases are impacting medical care. And as a response to this, there's a lot of pushback from the medical system, specifically physicians, with some saying that it's impossible for implicit biases to be in the medical system, and with others even going as far as to say that it's actually necessary to have implicit biases in the medical system. One example of this is a New York Times article where Dr. Sally Satel essentially states that her and her colleagues all practice racialized medicine and treat their patients based on race groups. And at the end, she states that stereotyping in medicine works. By the late 2000s, so approaching 2010, though, we do start to see a change around levels of advocacy. And with this, we're going to start to see a shift in perception. So between 2010 and 2020, there really isn't a change in the data around Black female maternal mortality, but where we do start to see a change is this rising level of advocacy, again, stemming from Black mothers and their families who are addressing the Black female maternal mortality crisis. And they're really doing this by sharing their stories and their family stories about what they've experienced in the medical system while pregnant or while their loved ones were pregnant. And this does two things. One, it's really useful for Black mothers. So Black mothers who may have already gone through their own pregnancy experiences are now coming face to face with these narratives where they have to reflect upon those experiences. And in doing so, a lot of times they come face to face with certain realities that they may have faced during their pregnancies that they may have just brushed off as a physician being disrespectful or busy at the time. And then it also serves to really help prepare other Black mothers for their pregnancies by giving them a glimpse into what is happening in the medical system and making it clear to them that's not an individualized issue, that this is an issue stemming from a larger system. And then the second thing it does is it brings awareness to physicians, public health officials, and then just the general population about what's happening, because you're hearing all of these stories. And even though each story isn't the same, there are a lot of common threads throughout them, really identifying the fact that this cannot be an individualized issue and that it is a systemic issue. So one of the driving forces of my thesis was using the testimonies of Black mothers and their families. And right now I'm going to share with all of you Deidre Johnson's story. So Johnson is a mother of two with a history of relatively good health and degrees from Princeton and Yale. But during both of her pregnancies, she came close to death due to HELLP syndrome, which is a severe derivative of preeclampsia and neglectful maternal care. So when Johnson went in to have her first child, she developed the symptoms of HELLP syndrome. And when she tried to bring alarm to her alarmingly high blood pressure to her physicians and her nurses, she was constantly dismissed, with even one nurse going as far to say that you people usually have high blood pressure, an idea stemming from racialized medicine. Luckily for Johnson, she had her family with her in the delivery room, and she came from a family of resource. So she was able to get in contact with another OBGYN who was able to confirm the severity of her symptoms and then get her the proper treatment. When Johnson found out she was pregnant again, she didn't want to experience the same thing she had gone through with her first son. So she decided to do extensive research on HELLP syndrome so that she would be able to communicate with her physicians in their own language, and decided to even deliver her child in a hospital that specialized in complicated births. But again, this wasn't enough. When she went in to have her second child, once again, HELLP syndrome came up again, and her symptoms just got worse and worse. And she continued to bring it up to her physicians using terms like vascular headaches and high protein urines. She continued to be brushed off. And like the quote on the slide states, she would have thought that she was a mute from Mars, because that's how much they just would not listen to her. And the only reason why she ended up getting proper treatment was because her family threatened to sue the hospital. So Deidre Johnson's story really points to how intrusive implicit biases and racialized medicine is within the medical system and how many mothers are confronting it. And in doing so, it really shows how Black mothers are now directly confronting this issue by sharing their stories and pointing to the fact that this isn't just something that's happening in one very specific instance. This is happening for many mothers across the board. And in doing so, it really forces all of us, I think, to take a step back and come face to face with these realities about how severe the maternal mortality, the Black female maternal mortality crisis is, and the fact that this is a larger issue that can't be solely addressed by Black females. So some of the larger trends that I look at in my paper is the historical dismissal of Black maternal health. So looking back to the 1940s, there's been a large effort stemming from public health officials and physicians to really quiet and nullify maternal mortality as a whole. So the whole crisis, including white and Black mothers, by making it seem like it's something that's curative. And this dismissal really disproportionately affects African American mothers because their race and inherent ignorance, as some would say, is used as a defense for not giving them the proper treatment, and then used as a defense once again if they do succumb to certain complications or even death. And you can look at certain behaviors like implicit attitudes, misogyny, and microaggressions for some of the reasons why we continue to see these issues coming about present day. And so the next trend is misplaced responsibility and blame. So throughout this presentation, I've really been focusing on the individualized blame narrative that's being placed on Black mothers. But it's important to also recognize that simultaneous to this individualized blame narrative, there's a triumphant narrative coming from physicians and public health officials who once again are trying to make it seem like maternal mortality is something that's curable, and specifically turning to prenatal care as that possible cure. And so this, once again, really disproportionately affects African American women, because even in present day, African American women are more likely to not have access to proper prenatal care, and therefore, once again, are being placed almost automatically in this category of blame for their own complications. And lastly is increasing advocacy stemming from Black mothers. So currently, 4 times as many Black mothers are likely to die from pregnancy-related complications as white mothers. And the sad thing is that statistic has actually stayed rather stagnant since it was initially reported in the 1940s. But what has significantly changed over the past decades is advocacy stemming from Black mothers and their families. And in turn, as this advocacy has only increased, the perception of the crisis has also begun to change as well, because with this advocacy, specifically sharing of testimonies of their experiences, the veil around maternal mortality, and specifically Black maternal mortality, is beginning to be lifted. And what we're seeing is that it really is a systemic issue. So it's important to realize that what this thesis aims to do is really confront what's been perpetrated for so long, and really force us all to ask if America can tell itself the truth about how it's arrived at this moment. And it's also important to recognize that this isn't a story of immense medical change, but it is a story of changing in advocacy, and how advocacy is being used now to dismantle a longstanding narrative of devaluing Black female experiences. So looking at the quote on the slide, I want you guys to think about all the Black mothers that, one, I mentioned in my paper, and specifically Deidre Johnson, who I spoke to you about today, who have historically had their trauma placed back on them and have been blamed for experiencing their own trauma, but are now taking their care into their own hands by sharing their stories and by making it known to others that we have to advocate for them, and that this cannot be something that they can shoulder on their own. And in doing so, we also have to realize that we can't change our history, but we also cannot continue to spread false paradigms around it. And this rising advocacy stemming from Black female maternal mortality is forcing us to come face to face with those false paradigms if we want to have a chance of improving, or at least addressing, the crisis effectively in the future. What all these female stories really show us is that there's been this large monolith narrative that's been perpetuated around Black female maternal mortality. And each of their stories really shows us that they're individuals, they're competent, they're responsible, and most importantly, they're all human and deserve proper maternal care. And for today, all of us can remember to keep on advocating, continuing to listen to Black females' stories and not devaluing them, sharing those stories, and then just talking about the issue broadly. Thank you so much for coming today, and I'm really looking forward to answering any of your questions. I'd like to extend a special thanks to my advisor, Dr. Beth Linker, as well as Dr. Megan Cernick, and my fellowship advisors, Dr. Green, Matt, and Gideon. And thank you again to my family and friends. Have a nice day.
Thank you so much, Morgan, and you as well, Angela, for your presentations. Now we'll turn things over to Raymond McCain.
Great, thank you. So thank you for the chance to read and engage with these 2 wonderful papers. I'm sorry you both had such beautiful slides, and I just have me reading my comments, but they were beautiful papers and beautiful presentations. And I was so impressed and kind of enjoyed the thoughtful engagements that both the authors made with the politics of health in the US in Morgan Taylor's case and on the African continent in Angela Kumirai's case. Both authors develop really creative approaches to thinking about the politics of health disparity in terms of race and gender in one example, and in terms of models of health financing in the other. And they offered really well-written and convincing arguments. So I hope both authors are very proud of what they've accomplished. I thought I would just describe briefly what I see as the kind of key points and strengths of each paper. So I'll talk about Angela's and then Morgan's, and then some questions for each of the authors and some questions that I had in common. And then I look forward to kind of discussing this material together. So Angela's paper, Healthcare Financing in Botswana and Ghana, a Comparative Study, asks this really timely and relevant question about the relationship between universal health coverage and healthcare quality by comparing these two case studies of Botswana and Ghana. And her question was so timely, not only because COVID has made clear to all of us the risks that accompany low or uneven levels of health coverage very close to home as well as around the world, but also because universal health coverage, as Angela explained, whether organized through public insurance programs or through the private sector, has increasingly become positioned as a kind of important horizon in global health policy making. And important global health institutions like the WHO are increasingly advocating for universal health coverage, or UHC. And I think one of the things that comes out really well in Angela's paper is that this goal is motivated both by the kind of aspiration to expand access to medical care and medical services, but also to manage health costs and health financing. And so it's also a response to a kind of logic of scarcity that is trying to think creatively about how we finance healthcare more expansively. So for advocates, UHC means we can expand services, we can include different actors, including the private sector, in the management of expenditures. And for some UHC critics, they would say, well, yes, UHC is great, but much depends on the kinds of services that are being covered and the way that we're actually enacting UHC. And so I thought Angela's paper really addressed this debate head on by asking, does coverage translate into access to high quality health services and better health outcomes? And she explores this by using a creative methodology that combines analysis of WHO data, a really deep literature review, and virtual and phone interviews. And she suggests that universal coverage does not necessarily equal better health outcomes or better health care. And as an aside, I think this is such an important question that's being taken up from many angles within global health policy debates. So there are various mechanisms for expanding access to care. So that could be efforts to strengthen health systems or expand health systems. It could be utilizing legal frameworks such as the constitutional right to health that some countries have adopted, or it could focus on financing mechanisms. And the debate in the US often kind of hinges on that question of how we finance health. And in all these different mechanisms, we see that efforts to expand access to care can do really important work in ameliorating health disparities, or it can actually exacerbate and kind of amplify discrepancies in the kinds of care that people have access to, or divisions between patients among the kinds of care that are made available. So this is a question that has much relevance beyond Angela's two case studies. So Angela's paper focused on Botswana and Ghana, which both have achieved close to universal coverage, but through these different mechanisms. So in Ghana, universal health coverage is financed through a 2.5% income tax, while Botswana makes use of government revenues based in the country's mineral wealth to finance public services. And so comparing these cases allows Angela to show that contributory health insurance schemes, as adopted in Ghana and as increasingly adopted in many places, do not necessarily improve healthcare quality or even health outcomes, and may in fact sacrifice important public health principles of equity and efficiency when compared with publicly funded alternatives. The countries are also different in important ways. So Ghana is larger geographically and in terms of population. The GDP per capita is about a third of Botswana. The climate is different. And all these differences also shape the kinds of health profiles of each country, although they're comparable in many ways. But perhaps the largest difference that I think Angela's paper really highlights is this mode of public financing that Botswana has made use of. So 98% of healthcare, Angela shows, is provided through public clinics. 54% of health costs are funded by government-controlled mineral resources. And then the private sector and individuals play also an important role. Although overall health expenditures are therefore higher in Botswana than Ghana, out-of-pocket expenses are much higher for Ghanaians. So the kind of everyday experience of patients in countries is quite distinct. And as Angela explained, Botswana also receives higher levels of aid per capita from donors and international agencies. So although much of the analysis of Angela's paper was focused on these financing mechanisms, I think the implications of the paper go beyond economics to actually think about the politics of health or health citizenship in these two places, examining how effectively patients and citizens are able to access health and are able to advocate or demand the kinds of health services that they need and want. And this is so relevant because her conclusion is that public financing of health, by providing greater access to specialty hospitals, larger medical centers, and more effective services, is resulting in more rapid improvements in care than the contribution-based scheme that Ghana utilizes. And so Angela's paper suggests that we can connect the ways that we pay for health coverage to broader ideas about and investments in health citizenship. So to the way in which health can connect individuals and communities to the nation state or to the body politic in either empowering or disempowering ways. And so one of my questions, I'll get to the questions at the end, but just as a flag, one of my questions was, how can we use these examples, or can we use these examples to reflect on the kinds of debates that we also have in the US, where the politics of health and how we finance health is such a kind of charged and important question. So Angela's paper makes a number of important contributions, both to our understanding of health policy, to the way that we pay for health services in different places and times, and to these broader political questions of citizen empowerment and patient empowerment. Morgan's paper also takes up from a different angle this question of health citizenship. In Morgan's case, it's reflected through race and gender in the US rather than through funding models on the African continent. And her thesis, An Untold Story, Understanding the Black Maternal Mortality Crisis Through Preeclampsia, 1940 to 2020, takes a historical approach to analyzing an important paradox. Even as maternal mortality rates have somewhat improved worldwide, maternal mortality rates in the US remain high. So for instance, she notes that in 2018, the maternal mortality rate in the US was 17.4 per 100,000 births in the US compared to the UK, where the maternal mortality rate was 7 per 100,000 births. So really dramatic difference between two countries that are comparable in other kinds of health measures. Moreover, American maternal mortality rates are characterized by appalling racial disparities between Black and white women's health outcomes. So this topic has gained increasing attention in recent years, as Morgan explained, and I think that Morgan's approach illuminates really powerfully not only some of the roots of this maternal mortality crisis, but she also reframes how this historical narrative should be understood. So she shows first that women's health in the US has always been characterized by racism. And in fact, I found myself wondering whether the very concept of women's health actually obscures as much as it reveals, given the very disparate experiences of women from different demographic groups, particularly Black and white women, but also women of different socioeconomic strata in the history of in America's health history. And this history of medical racism has meant that since the 1940s, poor maternal health has been racialized and individualized, so that poor health outcomes are interpreted not as a function of inequitable health distribution, physician and institutional racism, or dramatic structural inequalities in American life, but instead has been attributed to the perceived negligence, ignorance, or shortcomings of Black women. And as a result, decades of health policy has focused on the idea that Black women are not, quote unquote, good patients and mothers, rather than addressing structural determinants like improving access to high quality prenatal care or institutional racism, such as doctors that may fail to hear or address women's symptoms and warning signs. Yet because the cause of poor maternal mortality numbers is not individual, these efforts actually do little to improve health while doing much to stigmatize and stereotype Black, pregnant, laboring, and postpartum women. So Morgan's thesis creatively combines a range of historical, statistical, journalistic, and other sources, which allows her to make creative and strategic use of individuals' women's stories. To orient this wide range of materials, she focuses on one common cause of pregnancy complications, preeclampsia, which is a hypertensive condition that presents at first with mild symptoms like swelling or headache, but can progress quickly and dangerously, resulting in seizures and even death. And one kind of speculative question I had was whether preeclampsia is particularly important and maybe particularly interesting because of the way it presents in these kind of mild symptoms at first. So it requires a physician or a medical practitioner to actually listen closely and take seriously what a patient is saying, and then it progresses so quickly. And so it's like a particularly illuminating vantage point, perhaps, to think about the broader kind of interpersonal dynamics that are producing poor health outcomes. So Morgan starts her story in 1940, just as childbirth was moving definitively into hospitals, especially in urban areas. She shows that this influx presented new challenges of managing patient population, controlling hospital infection, and preventing complications. As the maternal mortality rate became an object of study and concern, she shows that state health boards and individual physicians observed that major causes of maternal mortality were preventable and could be resolved by better or earlier prenatal care. This was understood to require greater patient involvement and education, so the solution to maternal mortality was understood to be individual changes on the part of patients. Once maternal mortality was considered to have been resolved or cured, medical attention then moved on to the question of infant health, as Morgan explained. So this shift from maternal to infant well-being consolidated the idea that maternal health outcomes are a product of individual women's choices, and other important questions like the context in which choices are made, whether women exercise control over the conditions of their delivery, the distribution of health expertise and health resources in our society, or the role of structural determinants like access to good quality housing in highly segregated cities. These questions all went unasked. Issues of inadequate hospital facilities, access to medical care or support, the kinds of funding questions that Angela is raising in her paper, or institutional and interpersonal racism and other social factors, thus get excluded from view in considerations of maternal mortality. And as a result, disparate health outcomes between white and Black pregnant women were understood to be an effect of poor patient behaviors on the part of Black women, rather than an effect of structural inequalities and exclusions facing Black and other minority women. So what I particularly liked about Morgan's approach is that while she builds on an existing body of literature on racial disparities in maternal health, her focus allows her to show that the current attention and gradual improvement in maternal health outcomes is not just a function of general medical progress, better technologies, or even quote unquote better patients. Rather, it's the outcome of Black women's health activism, as women have spoken about their experiences and as social movements such as Black Lives Matter have raised awareness of both health disparities and the impact of interpersonal and structural racism in Black women's lives. And so this has raised awareness among pregnant women, as Morgan shows, but it has also helped women to advocate for their own needs and health in institutional settings. And I think it really provides an example of how we can conceptualize research that aims not only to document or kind of illustrate health disparities, but also to highlight the kinds of work that are done then to ameliorate or repair those differences. So I'll ask a couple of questions for each author and a few points for both, and then I'll wrap up. So my questions for Angela are, first, thinking about the kind of different methods that you and Morgan took to answering your questions, I wondered what a kind of more granular approach might lend your analysis, something comparable to the way that Morgan incorporated individual stories. So I know that you did phone interviews and you talked to providers. I know we are also all working under the constraints of COVID. And so part of my question is just, how do we think about research in this moment? If you had, unlimited resources, unlimited time, the chance to travel or talk to patients, What do you think patient perspectives might tell us about universal health coverage? Or what kinds of questions would you be interested in asking patients or community or family members about their experiences? Some of the things that I was curious about were whether we would see differentiation between patients of different socioeconomic status, what the role might be for private providers in Botswana and Ghana, and whether this is part of the difference in health outcome or the distribution of kind of health possibilities, whether there's even a role for alternative health practices in the kind of universal healthcare model. So who are the different kinds of providers and stakeholders in these two places? So that's one question. What would the granular approach kind of offer us? Second, I was interested in hearing, and I'll ask this of both of you, about the kinds of choices that you made as authors and researchers. So I would be interested to hear more. You explain in your paper a little bit about how you kind of choose Botswana and Ghana. They've both achieved kind of impressive metrics. They both have a broadly democratic and kind of approach to organizing health services. They're Anglophone. They share certain kind of historical, political genealogies in common. Were there other countries that you considered, or sort of how did you make choices either about these case studies or about the kind of data that you wanted to incorporate? What decisions did you find yourself having to make as a researcher and author? And then finally, as I kind of flagged earlier, I was curious about whether you see these examples as having relevance for debates that we are also confronting in the US about Medicare expansion, about the burden of rising healthcare costs, the role of healthcare costs in personal bankruptcy, and the kind of very immediate ways in which we have seen the health costs of inequitably distributed resources amid COVID. So are there lessons that we can draw from Botswana or Ghana or other ways of conceptualizing universal healthcare that might inform debates that we're having here in Philadelphia? And then for Morgan, my first question also kind of concerns the role of different stakeholders in your story. So one question that I had was about the role of physicians in these dynamics over time. So you show how physicians historically have often been resistant, even when confronted with data showing that racial bias is shaping health outcomes. So you give the example of Sally Satel and others. There was recently one of the editors of the Journal of the American Medical Association, or JAMA, said that in a podcast that he didn't believe that racism was really an important kind of factor shaping health outcomes in the US. For whatever it's worth, he was also very vocally criticized. So maybe that's whether it's disheartening or heartening that he received strong criticism. So there's this kind of resistance on the one hand. On the other hand, we can find historical examples where activist physicians have actually played really important roles in reforming medical practice. And today, groups like White Coats for Black Lives are working to transform medical institutions from within. So going forward, do you see patient advocacy or women's advocacy as enough? What is the role of medical practitioners and medical educators in kind of changing health outcomes? Or what other groups and institutions do you see as relevant or important here? So that was the first set of questions. Then I was also interested in the tension that you draw between maternal health and infant health. And this is something that we see in so many areas of health. So we see it in global health programming, we see it in HIV treatment, we see it in mental health care, where often infant health kind of ends up eclipsing attention to the health needs of pregnant women and mothers. So do you see ways in which we can better link maternal and infant health rather than kind of positioning them as zero-sum areas of intervention that are competing with one another? Then third, as I said, I really like this kind of narrative of patient advocacy. And in my sort of observation or recollection, part of what has driven contemporary narratives around the maternal mortality crisis facing Black women has hinged on the role of either very well-known or very impressive women. So I'm thinking like Serena Williams, for instance, and this response, like even Serena Williams faced this situation, right? This kind of public narrative. Or many of the women that you highlight in your story are extremely impressive, like have PhDs, are working at Harvard. And on the one hand, that platform maybe lets them speak out in ways that are not available to people. But it seems to me that it's also kind of ambivalent, because we also need to be concerned with women who are just, not world famous celebrities or whatever it is. So what role do you see for public figures, and how do you see this narrative as kind of, what do you see as like the contributions or pitfalls of the kind of public narrative that is emerging around this question? And then finally, I was interested also in hearing about your research and writing process and the kinds of choices and decisions that you made. So, how did you decide which women's narratives to include? What kinds of sources for these personal stories, which are very moving and effectively deployed? How did you think about locating them or incorporating them into your story? Did they lead you to new questions that you might not have otherwise asked? So thank you again to both the authors for asking these important questions and answering them with such thoughtful and important pieces of research. I think both papers made clear to me how students are taking up questions of the politics of health and the politics of health citizenship in such important and compelling ways to advocate for better health outcomes in the face of both global and local structural inequalities that are inequitably distributing health resources and life chances. So I found them inspiring as well as interesting, and I look forward to hearing more from the authors. Thank you.
Thank you so much, Ramah, for your comments. We'll turn now to Angela and then Morgan, who can respond to you, Ramah. And then again, people in the audience, there's a nice group here. Put your name down and hopefully we can get to your question in the remaining time as well.
Well, first of all, Ramah, thank you so much for explaining what the project was. I think you did it better than I would have explained it. And I actually started understanding the project even better after you talked about it. So your first question about the granular approach that I would have taken, my initial proposal to the Andrea Mitchell Fellowship was to spend time in Ghana and in Botswana at health centers in Kumasi and in Gaborone, just experiencing everyday health delivery in these centers. But then that was not possible due to COVID. And so I had interviews with people who I knew from a previous visit in Ghana. I had an interview with the head nurse of Komfokoche, I hope I'm pronouncing it correctly, hospital, which is the biggest hospital in Ghana. And I also had interviews with my roommate who is from Botswana. So the reason why I chose Botswana and Ghana is because these two countries are trailblazers in the field of healthcare on the continent. Ghana, as I also outlined in my report, that they are way ahead of other countries in combating COVID because of their very established and mature research base. And then Botswana is also coming up and outperforming in different areas concerning health in Africa. And then for the third question of the relevance of the debates, the US uses an employer-based contributory health system, and this benefits people who are employed. But then those who are not employed or those who have part-time employment that does not offer health insurance resort to using Medicaid. But then the pitfall of this is that different states have authority over what the poverty threshold is. And so in some states, the poverty threshold is for eligibility of Medicaid is set very low, such that some people fall through the gaps. So the relevance of this paper is a call to action to recognize healthcare as a human right rather than a privilege. And so if country resources are pulled towards healthcare that would give more access and probably better quality healthcare to citizens.
Great. So now we'll turn to you, Morgan, and then there's a question from Maggie Cernick once you've spoken, Morgan.
Thank you. So to start off with your question around the role of physicians, and then more broadly, how is this just an advocacy effort stemming from Black women, or how should others be involved? I'll start with the latter first. But how I see it, and I feel like I kind of get to it by the end of the paper, is that there's right now a huge effort stemming from Black women and their families who are sharing these testimonies and really powerful stories about what's happening broadly. And what I've seen is, as more of these testimonies have come out, there has been more and more involvement, as you mentioned, from other groups. And I think that's probably where we want to end at the end. As I was saying at the end of my presentation, it's important for not just Black mothers to be advocating. It's important for everyone to be taking up some sort of responsibility for talking about the issue and sharing the story around it. And I think it's more of a gradual process, where the reason why in my paper I solely paid more time focusing on the Black female and their family's advocacy role is because, especially over the last 10 to 15 years, it's been so clearly documented. And then when it came to, because I did try to look at physicians and their role in it, just to make sure I was covering both sides of the argument, was that right now what was very publicly available is a lot of the pushback to implicit biases being in the medical system and racialized medicine being present in the medical system still. But there is efforts to start combating this. I think around 2 weeks ago, the CDC actually came out saying that racism will have an effect on the whole country's health. So that's already a huge step, just showing how larger systems are now taking up this stakeholdership in dismantling the larger narrative. And I think it is really important that you have those larger stakeholders, because you can't rely on Black mothers to continuously also have to take up that stress as well of advocating for themselves and trying to prove that their health is worth something. But right now, I feel like their story serves a very powerful foundation for understanding the crisis at large, so that people of other backgrounds and other positions can properly advocate for the issue. And then for your next question, on terms of infant mortality and maternal mortality, I think it's really interesting. So I didn't touch on it as much today in my presentation, but in my paper, I really focus in on how in the 1990s, there's this shift to focus in on infant mortality over maternal mortality, because there is a dip in the general maternal mortality rate around 1990s in the US. Black maternal mortality is pretty much stagnant, but generally it goes down. And during that time, there's a really large push around infant mortality. And that's also happening globally, where we're just focusing more on infants. And what's really interesting is, in a lot of the pitches to solve infant mortality, it's a lot of things that would probably also address maternal mortality. But in a lot of that literature, you see a separation between the infant and the mother, even while the mother's still carrying her child, which I thought was particularly interesting. And that mindset starts to frame this idea, and this is an idea stemming back even to the 1800s, that when a mother gave birth, it should just solve all of her issues, and then you can solely focus in on the infant. So when infant mortality became a larger and larger issue in the 1990s, I think that idea starts to come up again really profoundly, thinking, okay, well, the infant is clearly causing the issues because she didn't have these issues previous to being pregnant. So as long as we deliver her child, that means this issue should resolve itself on its own. And it's interesting because with certain complications, if you do catch them early enough, delivering the child really can solve and remify whatever complications the mother is going through. But then with other issues, and I used one during my paper in the introduction, a mother develops a heart condition while pregnant, and delivering her child does nothing to fix that heart condition. But I do think there is room for both of them to be in discussion. And I do think currently, as more attention is starting to again be paid to maternal mortality in general, and specifically Black female maternal mortality, scholars, physicians, different stakeholders are having to be in more conversation with, again, focusing in making sure the infant's safe, but also making sure there's someone who can pay attention to the mother, making sure that the mother makes it through as well. And then, so I was really happy you asked your third question about the narratives that I chose to use, because that is one of the where we go from here questions that I ask in the paper, is the fact that right now a lot of the stories are coming from either well-known women like Serena Williams, or women who either come from backgrounds of wealth or high education, and there's less from just the regular woman or even someone from a lower socioeconomic status. And I think it's very telling, because in one article that I read, it does talk about a woman from New Orleans who is lower income and her experience. And as a result of that article, a lot of women from higher backgrounds, people with PhDs, women of wealth, all responded saying like, oh, this is happening to me too. And what was interesting was when I initially started doing my research, that was the article that came up first, not the article that spurred the response to it. So I think that's very telling. And I think there's something powerful about, one, that we have women of higher standing coming forward and saying this is happening to me, because I do think because of the history of the individualized blame narrative and just the history of how we typically perceive African-American people in the US, it is important, one, to just continuously see African-American people in higher standings, and then to say, okay, so clearly this person isn't incompetent, clearly they're responsible, and those are typically the defense for them then succumbing to these complications. But I think, and something I did begin to see throughout my research, was there were more and more normal stories coming up. And I remember this when I was doing my first paper my sophomore year, and I was constantly Googling articles. It got to the point where I would just be on social media platforms, and my targeted ads started to be just news articles of women from small local towns with their families talking about what happened to them. And there was one article that I did use, I think, in the introduction, where the mother had sadly passed away, and her husband ended up writing an article and being interviewed for a local small newspaper. And he talks about his wife's experience, and they're very much like a normal family. So I think as more and more stories have started to come out, more people are just coming forward and talking about it. And because you're seeing such a huge uptick in people wanting to read about it, it makes it easier for Black mothers or the families of mothers that have passed away to say, okay, no, I'm going to now submit this, or I'm going to talk to someone. And the use of social media platforms also makes it easier now for people who might not have that existing platform to be able to speak up. But I do think that is a space where there has to be a lot more uptick around it. And then your last question on my research strategy. So throughout the paper, and you mentioned this when you were reviewing it, I use a lot of older newspapers, magazines, and public health records. And on top of that, tie in those testimonies. I think for me, that was probably the hardest part of researching, was I was starting to be able to gather so much data and all these really interesting narratives and stories, and trying to determine which stories to include and which ones that I wasn't going to include. And I think when it came down to including interviews, even the ones that I didn't strategically quote in the paper, I felt like their stories were in the back of my mind when I was writing, especially when I'll be talking about different perspectives that even Black women were having on their care experiences, and making sure that I wasn't trying to draw a general conclusion, and making it clear, as I stated in the presentation, that each of these people is having different experiences. There are common threads throughout them, but they're each different. And I think that was one of the guiding things for what testimonies I did choose, was there were certain ones where if you looked at them generally, they looked very different, but then reading them, there were very small little common threads that continued to become present. Or with certain testimonies, like I used one testimony for my chapter on the 1960s. And that one is one of my favorites just because there's very few from that time period. And it really backed up a lot of this really interesting data that's just available from that time period about the hospitalization movement for just giving birth in general in a hospital. And then looking again, because that testimony shows the difference between giving birth in an urban hospital in Westchester versus a local facility in Kansas. And you see this huge change in how the woman's care is treated. So I think that was one of the reasons why I chose certain interviews, was it helped to bring life and narrative to the data that I was collecting, especially during those earlier chapters. So probably 1940 to 1975-ish, where there was very few testimonies that I was able to collect, but the testimonies that I could find really brought to life those, either those newspaper articles or just general information that I was finding.
Thank you so much, Morgan, for your response, and you too, Angela. We are a little bit over time, but I do want to give Maggie Cernick the chance to ask her question and give whomever she's asking the opportunity for a brief response before we wrap up. We'll have our next panel at 11:15, so we are running out of time, but it's a tribute to all of your fine work that it's ignited this discussion, and I would just draw your attention to the chat comment from Jasmine Blanks-Jones that just come over the wire a moment ago as well. So Maggie.
Thank you both for these wonderful and very thoughtful presentations. So my question I have a question for each. For Angela, my question was about the sort of connection between natural resources as a potential to pay for universal health care. And I was really struck by that because in sort of my sort of studies of environmental health, like those are never really beneficial to the workers, or often have negative health consequences, both for the communities that live close to those industries, as well as the workers who are working in them. And I was wondering if there was any discussion of the sort of health impacts of those types of work environments. And for Morgan, my question was about your discussion of blame. And I was really intrigued by that because in, sort of a lot of the sort of history that I'm familiar with is that mothers are almost always blamed for the their negative health impacts on themselves, on their children when they're pregnant. And I was just wondering if you saw sort of any points of connection between the narratives of blame that are surrounding Black women and other groups that have often sort of been targeted by these blame narratives, like immigrant women. I'm particularly thinking of in the early 20th century, where also you saw a lot of this rhetoric. So maybe just briefly where you saw points of connections or difference, and whether or not, because you ended with this kind of note of advocacy, if you saw any sort of potential for coalitions between and among mothers, even across maybe different races, because I think that there's a lot of power in that statement that you made.
Oh, yes, indeed. The reason why I focused the study around the natural resources of the country is because that is a huge source of revenue that countries have control over. So in the case of Botswana, Botswana has many diamonds, and they have partnerships with the De Beers company where they humanely produce diamonds and get a lot of revenue from that. And in the case of Ghana, they are large producers of gold and large producers of cocoa. So an example that we saw stemming even from Penn was Shadrach Frimpong, one of the first people to win the President's Engagement Prize from Ghana. He created a self-sustainable model in rural Ghana, in Tekwa Brennan, where he comes from, where he essentially organized people around his community, cocoa farmers around his community, to farm cocoa. And then when they sold it, the revenue that they got from that was used to fund a public hospital and a public school. So this was one of the examples where the natural resources of a community can be applied to improving health access and quality within a community.
Hi, Maggie. So in terms of your question, I think it is really interesting when you look at the blame narrative just generally across mothers. And in my earlier chapters, I think the end of chapter 1, beginning of chapter 2, when you're looking at this narrative around prenatal care being curative, or just generally how we're categorizing maternal health. What was interesting about writing that portion of the paper was that was all really from the perspective of white maternal mortality, because Black maternal mortality wasn't even being noted in those reports. And so I do think it's interesting that those things did make it clear to me that this blame narrative did span across all the mothers that they were looking at in those reports, because they were still saying, okay, if you still can't get access or you're not cooperating with physicians in the way that we think you should be, then you are going to be blamed for, or have the potential to be blamed for, whatever response that or outcome you have from your pregnancy. And then I do think there is room for those other narratives across other demographics in the US. One study that I read but I didn't include in my paper actually did discuss it between Hispanic women, Native American women, and African American women. And that study is really interesting because it showed a lot of similarities, but at the same time, surprising to me, a very large amount of differences, where I think within certain communities, what they showed was like the Native American population, a lot of them still give birth within, if they live on a reservation, on those reservations. So those certain things where like you might need to advocate for yourself more aren't as necessary, because they're with people who are going to respect them and understand like what their needs are more so. And then when it came to looking at, they compared all 3 groups to each other. The authors talked about, because of the history of racism in the US, it does put Black mothers almost in this other category, because there's such long-standing ties around just racism in terms of medicine, then just in terms of how you're viewing Black people in general's behavior, where we don't have those same overarching narratives for other groups of people. But I do think that moving forward, there is room to have those broader coalitions of groups of mothers coming together. And I feel like this ties to one of the earlier questions that I answered about like advocacy and who gets to play a role in that. And I really do think it's not just like a Black mother advocating or being able to share those stories. It really should be eventually sharing those broader stories about where we see systemic issues in our current medical and public health systems.
Well, thank you all. This concludes the Health and Policy Today panel of the undergraduate conference at the Mitchell Center. I want to thank Morgan Taylor, Angela Kumirai, and Raymond Mccain for their great contributions to our first panel today. We're going to push back our second panel by 5 minutes. And so our liberalism, illiberalism, and neoliberalism panel will begin at 11:20.